Plasma is a yellow-colored fluid, about 91.5% water. The rest, 8.5, is solutes. And they're going to transport red blood cells. Here's a classic biconcave disc to our right. Platelet, involved in blood clotting. Leukocyte, or white blood cell, for body defense. Crazy looking thing. And all of this transported in plasma. Albumin's also in plasma, which regulates pH, transports toxins, waste out of our body, and reduces edema. So if we have albumin problems, sometimes a kidney issue, then we expect to see some localized edema. Globulin proteins, they're going to attack invading bacteria, thank goodness for that. And fibrinogen, I'll be talking about clots and fibrin. About 55% of our blood is plasma. I mentioned how it transports cells, but I didn't talk about the electrolytes. Here's electrolytes, just one of the many ingredients of plasma. Sodium, potassium, and magnesium chloride, all dissolved, and they help maintain this osmotic pressure so that fluids move in and out of our cells. Urea, uric acid, creatine, creatinine, similar word but a different substance. These are often due to a kidney issue. Bilirubin, ammonia, all of these they tend to be byproducts of natural cellular activities, and they're not a problem unless they stay in the body, and plasma helps us to get rid of them. Hematocrit is the percentage of total blood volume occupied by red blood cells. So we want about 38 to 46 in an adult female, 40 to 54 in adult male. Those become important when you have a patient who's sick. You pay close attention to that hematocrit because it involves lots of things. In fact, hypoxia is oxygen deficiency that is detected in the kidneys, and it tells the body, hey, we need more red blood cells in our plasma. And now the kidneys are going to make this erythropoietin, EPO, it's easier to say, and that stimulates the red bone marrow to make more RBCs. And that's a process called erythropoiesis, based on this word erythropoietin. And that's why you pay attention to these hematocrit. Getting back to the real world, if their hematocrit's low, then that means we need to stimulate the bone marrow. Anemia is when there's not enough red blood cells, and the problem is there's not enough oxygen. And if there's not enough oxygen, then these patients, they feel cold, they feel weak, they're going to get infections. Once in a while, we do have polycythemia, high hematocrit. It can be artificially increased through EPO injections, but often it's due to illness. RBCs, they contain hemoglobin, HB. And that's just that pigment that binds to oxygen and gives blood its red color. Anytime I have patients I draw blood from, I tell them, hey, that blood is being replaced. I don't tell them 2 million cells per second, but that's to compensate for the number of cells that are destroyed. These guys only live about 120 days. There's no nucleus, and there's no organelles. See, they need this space for storage of oxygen. And so the price they pay is a short life. They also may pick up some nitric oxide as they pass along the blood vessels, and then they'll dump it in different areas, and it causes localized vasodilation, so enlarged blood vessels. And we see that in it's a localized sort of process. Blood groups, ABO groupings. Well, let's just look at. We have A type of blood that has A antigens, markers on the surface, but they have anti-B. That means if B blood is introduced, then A is going to attack it. Because it sees it as foreign. It says, hey, all my cells have A's, and you have B's, which look different than me, and I don't know who you are, so I'm going to destroy you. And that's why when we transfuse blood, we've got to try to do a very important serial typing. So B has a similar situation. It has its own B markers, but it has anti-A, and it's going to attack A. AB is a nice situation because both types of surface markers are present, and so they'll recognize A is okay. Hey, you can transfuse to me, or B to transfuse to me. O is a good universal donor because it has no of these types of surface markers. It has other kinds, but not these. So it can go to AB, B, and A. So if you're out on the desert in the Sahara and you're bleeding to death and someone comes up and says, hey, Saeed, I can transfuse my blood, you're in a tough situation if you have O, because if this guy has AB, B, or A, you're going to die. The best thing to have is AB for as a universal recipient. Anemia, I mentioned this, fatigue, cold intolerance, because we need oxygen to make ATP energy. And so these people just, they don't have enough energy to even keep their bodies warm. It can become a problem. Iron deficiency anemia is the most common type, and women, of course, during their menstrual blood loss, they have periodic iron deficient anemia. Megaloblastic anemia is if you don't have enough vitamin B12 or folic acid, and so we don't produce the red blood cells as we should in the red blood marrow. Pernicious is related to megaloblastic, except there's some sort of problem with it's often a lack of an intrinsic factor, the far right, that interferes with the absorption of vitamin B. And finally, hemolytic. I'm familiar with this one because I lived 2 years in Africa, working there in the bush, and parasites would mosquito parasites would give me malaria, which would hemolyze or give me hemolytic anemia. But then Peter, who I worked with, Peter Muga, he had genetic sickle cells, so he would suffer from hemolytic anemia from sickle cell anemia. So we both had it rough. Blood doping, that's where you artificially induce that polycythemia. Remember that where we can increase the production of red blood cells. We use epoetin alpha to treat anemia. Like we have a patient that's chronically anemic. We want to kickstart their red blood cell production with artificial injections. Problem is athletes sometimes will do this without being regulated. And if you get too many red blood cells, then the blood becomes viscous, which means it's thick. You know, it's like motor oil, and we don't want that. It increases the heart workload and increases heart attacks and strokes. And bicyclers especially seem to love EPO. I mean, other athletes do as well, but we see lots of strokes and heart attacks in these athletes who look so healthy. So be careful of this stuff. The best way is natural blood doping, and this is done by training at high elevations. Mount Kenya, which I've climbed twice, and I can tell you, it is, you get up there and you can't breathe. There's such low levels of oxygen. But after a while, if you train up on Mount Kenya, then you go run the Boston Marathon, and you just blow everybody away. And that's what's often done. These people, people that train at high elevations, they know what they're up to. Hemolytic diseases of the newborns used to be called erythroblastosis. I know there's a lot of writing here, but let's just focus on the basics, okay? Dad has blood cells with the Rh factor. Mary's mom, they have a baby. The baby inherits dad's blood type with Rh factors. Now, during the first pregnancy, usually right near the delivery or the baby's kicking around, elbows the mom while in her uterus, there's a little blood leakage, and the mom starts to say, hey, I got the wrong blood type in here. We got to destroy it. Now, of course, she doesn't mean to do that. Her immune system does it. But usually that first baby's born just in time. But now, let's go down below. Here's mom, and her immune system has produced anti-Rh factors. And so the second pregnancy, we got a problem because the mom immediately recognizes a foreign object, or I shouldn't say object, a foreign body, and her anti-Rh antibodies pass across the placenta, and we have the blue baby syndrome. The baby's blood cells are lysed. We can prevent that anytime we have a Rh negative mom, we're going to inject Rh RhoGAM antibodies. Any of it, she says, no, my husband is negative. He's already been tested. We never trust the patient because patients don't always tell the truth. And so we say, okay, that's nice. Your husband's Rh negative, but we're still going to inject you. And so we do. We do it just prior to birth and then after delivery. And that inactivates those fetal antigens. And so there's no problem. We don't have to go through all this. Oh, white blood cells, we're on to a new type. They do have a nucleus because, they're not storing oxygen. They have granules, which they all have granules, but some stain. And that's why we call these granular leukocytes. Neutrophils are one type. The nucleus has several lobes. Take a look over here. You won't see this on a blood slide. You won't see all these blood types on one slide. You have to search for these guys. They're going to be increased during bacterial infection, burns, stress, inflammation. Eosinophils, these tend to be the guys involved with allergy, when you have an allergic reaction. High numbers of eosinophils, but also if there's parasitic infections, autoimmune disease. Basophils, also allergic. Leukemia, cancer, hyperthyroidism. These are the agranular guys. Lymphocytes have a huge, take a look here, lymphocyte, large rounded nucleus. Sometimes there's a dent in one end. Increases during viral infections, leukemia, mononucleosis. Monocytes, these babies are massive, and they have this foamy looking cytoplasm. Increase during viral infections, tuberculosis, leukemia. And they're going to migrate out. I'm going to talk about those in just a minute here. Here we go. They migrate out and become phagocytes. So the words immigrate when they move out of the bloodstream and into tissues, and they never go back once they're out. Now the neutrophils, which are here, they have the multi-lobe nucleus. They are often the first responders in high numbers, and they're going to engulf and here we see it. Here's some bacteria, and they're engulfed and destroyed by these lovely neutrophils. Eosinophils and basophils, what they do is they're going to attract more phagocytes. So they release this substance called histamine. It's like handing out $10 bills on a street corner. You're going to get lots of attention, and so that infection site becomes warm and filled with blood and phagocytes. Leukemia is where we have an overproduction of abnormal white blood cells, which doesn't sound terrible, but the problem is it's going to suppress the production of red blood cells, platelets, and other cells that we need. And it's the opposite of leukopenia, which is low concentration. Here we have a good visual. Normal blood with looks like a neutrophil, lymphocyte, platelets. Now look at not many red blood cells and an overproduction of, looks like monocytes here. Yeah. We're not sure what causes leukemia, but maybe triggered by radiation or chemotherapy. Genetic, certainly genetic is huge. Environmental factors, benzene and smoking have been linked to it. Thrombocytes, this is where they break off from a megakaryocyte and they join with a fibrin, which they help to initiate, and they seal a wound. And I'll be talking a little bit more about that in the blood vessel lecture. So let's just get, this is called hemostasis, controlling blood loss. Blood can be used by taking it from the iliac crest, and hopefully the donor is you, and in that case we don't have a graft versus host reaction, which happens when we take it from another patient. And that's why we've gone to the cord blood transplants, because the infection risk is lower, and so is the graft versus host reactions. Now, there's some debate about this by people who don't really understand the process. The parents of the child, of course, are asked for permission, and this is a very sterile procedure done with the umbilicus, and this is going to be cut anyway, and so there's no damage taking place here.